So as is common, what I'm going to do is go over some concepts to just show them to you in action, right? So we talk about the concepts of assessment and the concepts of treatment. Generally speaking, with assessment, one of the keys is macro identifies micro, so a large motion to show the smaller problems that would exist within that larger motion, because each large motion is made up of some components. So as far as the vertebral column is concerned, when the patient is in prone, it's exposed, so this is patient positioning. It's exposed, it's free to move in some planes, but not all planes that may be required, and it's visible, right? So I get to use multisensory integration, or keep your hands and your eyes on the prize, right? So a very, very quick, simplistic way to test, so assess, and then formulate some form of treatment for the vertebral column in a prone position. Not necessarily the cervical column, because the cervical column is somewhat more difficult to treat in prone, not impossible, but it is somewhat difficult. But one of the easiest ways to check the vertebral column, now this is not pure vertebral motion, this is relying on pressure changes in the abdomen and in the thorax to highlight what does and doesn't move. Okay? So essentially all I do is I put my hand in and around the cervical region very gently, and I put my hand in and around the sacrum. The reason I do this is to create essentially a window for me to look inside of. Then what I'll do is I'll have the patient take a deep breath, and let it out. And then what does and doesn't move, right? So the lumbar column moves fairly well, visually speaking. Now I don't expect the thorax or the thoracic vertebral column to move large. I don't expect a lot of movement out of it, but I do expect some, visually at least. So visually, the lumbar column moves fine. I place my hand inside the lumbar column, but that's basically because I want to take it out of my visual picture. My thumbs will start to extend here. Take another deep breath. And let it out. Okay, and again, everything seems to rise and fall, right? Lower in the thoracic region, but not as much in the upper. Again, I expect less motion in the upper thoracic region because the ribs will not create as much excursion, so the change in pressure in the thoracic region will not create as much pressure. But now I come into the area, so the lower thoracic region seems to be moving fine, at least upon deep breaths, right? Then I bring my thumbs in together, so again I make my picture smaller, take a deep breath, and let it out. Okay. So essentially, I'm looking at somewhere in this region with respect to the vertebral column that is not moving as would be desired, right? So I go from macro to micro, or a macro motion, and essentially coming into a smaller area, right? So again, what I do is I just use hand high in the thoracic region, or generally very gently in the cervical region, hand low at the tail, take a really deep breath, and let it out, right? Then I move into, so if everything kind of looks okay in the area, I exclude it, take another deep breath, and out. Right, so again, right around here is the area based on what I'm finding on this test. Now, is this assessment methodology clean, pure vertebral motion? No, it's not. But what is happening is as the patient is changing the pressure gradient in the abdomen and the thorax, mobile vertebral segments should move a little bit. They should express some anterior-posterior motion. When they don't, they're easy to identify. So at this point, what I would do is I would think about my concepts of, essentially my concepts of treatment. So patient active or patient activity, are they active or passive? The tissue or tissues targeted, and then the barrier, right? So the barrier, if there is pain upon what I'm going to attempt to do, I will go indirect. If there is no pain, I will go direct. But essentially what I'm looking at is in this region, I want to assess the soft tissues, right? So when I work on or assess soft tissues, I go perpendicular to fiber direction. To assess this side, I would probably more ideally like to come over around the table, but I won't do that for the case of the video, right? Because I want to test in a similar fashion. I want my testing to be consistent, but I would test soft tissues, and then I could create essentially a spring on the hard tissues, see which one I'm more concerned about, and then I could choose a more appropriate method. As far as activating forces, you want to be organized in how you do them, so compression, distraction, torsion, and shear. I can create some shear, I can create some torsion, I can can't necessarily create compression or distraction on the vertebral joints, but I could create posterior to anterior force. And then I would choose whether or not I want the patient active. So all of these things kind of come into play, and then it would look something like this. So if I've decided for whatever reason, based on further assessment, to treat right here, and I want it to be a patient active, I could have the patient take a deep breath, and out. All right. I can ask you, push this down onto the table, and then let it go. All right. Push this down on the table, and let it go. So those are patient active. So it's patient being active away from the muscles that I'm working on, because when I have the patient contract the muscles I'm working on, it can be quite uncomfortable. Right? Push this shoulder down, and let it go. Other shoulder, let it go. All right. So based on that, what I would do is see which one gave me the most, which one or ones gave me most of what I wanted, and I would continue on, right? But then we're looking at myofascial release mixed with patient active. So I could do all of that, and then that would form a treatment, and then I would reassess. Now in my reassessment, in the manner in which I would reassess, I would have determined, or I would have excluded the areas that are moving freely, and on reassessment, I would go to the area that's moving poorly. I don't need to do the rest because I've already done it and proven to my satisfaction that it's all going okay. So my reassessment would look much more simple. Just take a deep breath and let it out. And were that an appropriate treatment, were that moving better, I would move on. Were it an appropriate treatment and it was not moving better, or I believed it to be an appropriate treatment and my reassessment showed me it wasn't moving better, I need to choose other methods. So all of this begins to sew together a bunch of concepts again so that you see them in action.